Welcome to MMR Accreditation Stage 1, Webinar 2. This webinar is about conducting a medication review. You will see that just as dispensing has a procedure, so too does medication review. As we move through the webinars, you will gain structured information to help you proceed with this professional pharmacist service role. After the webinar, you'll be able to explain a comprehensive process of medication review, compare relevant tools of medication review, and discuss how to identify, resolve, and prevent actual or potential medication-related problems. The professional pharmacy standards are the basis for this service, and I've made a huge list here which I'm just going to quickly run through, because you will see that Professional Standard 14 is about medication review. It's a patient-centred service. It's a collaborative service. It has policy and procedures. It has education and training for pharmacists. There is assessment and consultation. There is service delivery. There is documentation and data management. There's counselling. There's continuity of care, there's monitoring, review and follow-up, there's storage and disposal, there's risk management, and there's evaluation of the service. So what are the reasons that we need medication review? Well, many more drugs are available. For example, in the 1950s, when the PBS started, there were 140 drugs. In 1996, there were 600 marketed as over 2,000 brands. The costs have gone from $149,000 when it started to $6.5 billion, with 195 million scripts. There's more sources of supply. There are more pharmacies, more internet sources both here and overseas, and of course they're always supplied by friends and family. Doctor shopping is still a problem, where some patients have a GP and a pharmacy in several suburbs. One can only consider what happens to that oversupply. Hospitalisation can also be a problem. Consider why people go to hospital. Usually it's an acute event. Fractures mean that often pain is involved. Acute infections mean antibiotics. Heart attack means a whole range of drugs are started. What the patient has at home are often not known. What do they do when they get home? Do they take both? Do they take the new stuff? Or do they just take whatever they like? There is a story of a nurse whose father had just come out of hospital on warfarin, and she decided to visit one morning before going to work. He'd been given warfarin 1 milligram, 2 milligram and 5 milligram in hospital, and he decided he'd take all three. Fortunately, she was able to contact the GP and find out what dose he was supposed to be taking, and then ask the pharmacy to pack his medicines for him. Polypharmacy, perhaps we should call it polytherapy, is the use of multiple medications by a patient. When too many forms of medication are used, when more drugs are prescribed than is clinically warranted, or even when all prescribed medications are clinically indicated but there are too many tablets to take. It's possible that there is symptomatic treatment and they may not be evidence-based. The most common results of polypharmacy are increased adverse drug reactions, drug-drug interactions, and of course higher costs. Polypharmacy is most common in the elderly, but it's also an issue among the general population. The National Medicines Policy is based on the QUM principles. If a medicine is needed, then a suitable one should be chosen wisely. It should be used safely and effectively. The term medicine is used rather than medication to include prescriptions, non-prescription medicine and complementary medicine. We hope you are right thinking this sounds like a home medicines review, because it is. Just to let you know that we'll be using some of the first webinar information in this webinar, as you would expect. So to conduct medication review, you need to have good clinical knowledge. Please consider if you need upskilling in any clinical areas. This knowledge may not be able to be used if it's not supported by good communication skills. If the language imparting the knowledge is judgmental, then the knowledge will be wasted. Good documentation is also important. Pharmacists are now learning to be documenters with clinical interventions and meds check and accreditation. Good management is also important. If the process of medication review is not managed well, then the pharmacist will find they become overloaded, and that will make the service not worthwhile. There are a few tools to do medication review. This one is called the No Tears tool. It stands for, we'll just run through them: need an indication of the drug, asking open questions, seeing what the tests and monitoring show, looking at the evidence and the guidelines, looking for adverse events, looking for risk reduction or prevention, and finding simplification or switches for the medicines. There's also a brown bag review. This has been a common practice that encourages patients to bring all their medications and supplements to medical appointments. This provides clinical staff with an opportunity to review and discuss the medicines the patient is taking. So reviewing the medications with your patient may help you to answer the patient's questions, verify what they're taking, identify and avoid medication errors or drug interactions, and assist the patient to take medicines correctly. Can you think of some inaccuracies in this process? Bring them with you on the workshop day. What we're going to show you is a very simple system of medication review, and it can be used for any patient with any condition. We're sure that as you become familiar with this new service, you will develop, improve, and make the whole process more efficient and make it your own. At each step of the process, you will gain information, and that information will lead to a question for the patient or a fact for your GP report. We encourage you to prepare questions before you go to the patient because it can save you time and make sure you gain the information needed and help you provide a professional service. During the process, you'll be able to identify actual or potential medication issues, and these will form the basis of your report. So step 1, using the GP information, list the medicines in disease states. This will help you to, firstly, identify if the medicines the patient has are the same as the ones the GP has listed. It may be that you have to delete or add depending on the answers the patient gives you. It gives you the number of medicines used. It will also identify how many medicines are used for each condition. For example, if there are 3 medicines to treat hypertension, it would indicate that the blood pressure has been difficult to control. And you might like to ask, how is it now? Are you still taking 3? So you've just started your HMR. You've started your interview questions, and you've also started your report. This is a useful tool because GPs consider medications in the context of conditions. So showing the medicines in their conditions can help the GP make a decision to change. For the pharmacist, they can identify if a condition has been difficult to control, and it may be that some of the medicine should have been ceased when others started. Step 2, consider the conditions. Is there treatment for each condition noted? If, for example, there is a condition without treatment, that would lead you to ask the question. Perhaps the patient is noted to have depression, but there's no treatment. Does it mean they've forgotten to write down the treatment? Or is it that the depressive episode is no longer, so there's no need for treatment? Is there a medicine listed but no condition noted? In the same way, someone may be taking an antidepressant but there's no diagnosis. Can you consider why a GP would order a medicine without a proper diagnosis? Perhaps it was a trial. Perhaps it was to treat symptoms of depression where they knew it was a self-limiting disease, for example, when a partner dies. Again, you have more questions to ask and more facts for your report. Pharmacists need to justify the use of a medication against a condition, or the medicine use needs to be supported by a diagnosis. So why would GPs prescribe a medication if there was no diagnosis? If the medicine is prescribed when a patient is 50, is it still the ideal medicine when they're 80? Step 3. Consider the treatment. If the diagnosis is listed, are the medicines ordered in line with recommended guidelines for this patient? For example, if a patient has asthma and you find they prescribe Ventolin, Bricanyl and Symbicort, you might like to ask if all three are used at the same time, or perhaps they've all been ordered at different times in the past. Consider if the medicine is used in line with the evidence available. Again, you have more questions to ask and more facts for your report. So where do we find evidence-based medicines? We need resources such as therapeutic guidelines, Australian Medicine's Handbook. We need guidelines from the Heart Foundation or the Osteoporosis Foundation. We need consumer-friendly fact sheets so we can help patients to better understand their treatment. Step 4. Consider the doses. Are the doses in the range recommended for this patient? For example, if a patient is elderly with a reduced renal function, then a lower dose might be suitable. Is the dose too high? For example, if a patient was taking higher doses than recommended for an iron supplement because their iron levels were below normal, you might like to ask, how long ago did this dose start? Is there pathology to show that iron levels are still below normal range? Is the patient having adverse effects of the supplement? What if the dose was too low? For example, if a patient was taking 2 paracetamol for arthritis with their breakfast, is that dose effective? You would like to ask how their pain was later in the day. Can they walk to the shops in the afternoon? Have they ever tried taking more doses? Using the pain management example, do you still have pain? Are you able to get around? Again, more questions, more facts. So to gain the information we need accessible, credible drug resources like eMIMS. We need to find out more information about the patient and their medicine use. Step 5, check adherence. So we can use the pharmacy history or medication chart to identify if the medicine has been dispensed, if there are other doctors, if there are other doses, if there are other drugs. There are several terms in use and we've spoken about it before. Good adherence means the patient is adhering to the doctor's instructions. Compliance is used when it comes to talking about medicine use, but it does have overtones of the doctor ordering the patient, so it's not used much now. Persistence is when the patient continues to take the medicine over time. Concordance is a bit different and it looks at the relationship between the patient and the clinician. So the GP has been given information on what the patient is and the patient has agreed to do it. So there is concordance. So the pharmacy history is good evidence of what the patient is having dispensed. Looking at the dispensing history gives you great information about the number of times medicines have been dispensed and if different doctors have been involved. If there have been different doses of the same medicine, it will be there. What would you do if these medicines, in fact, were not on the GP list? More questions. If you need to gain a pharmacy history, and you would need patient consent to do so unless you're actually working for the pharmacy. What are the issues affecting adherence? We've done a little bit of this before, so I'll be very quick. Knowledge. Please tell me how you take your medicine every day. You're sort of verifying what you think you already know. Do you feel like you've got too many medicines? If they say yes, then maybe the aim should be to reduce the number of medicines per day. Do you sometimes forget to take your medicines on routine days? Maybe if they do, they need some sort of DAA or a reminder. Do you forget on non-routine days when you're travelling? Maybe they just need something packed when they go away. Do you have a concern about your medicine is not helping you? Now, this is really important because some patients simply just don't take it because they think it's not helping. Do you feel you don't need this medicine? Have you had any side effects? Sometimes that's a hard one, I feel, because they often don't know what the side effects are. So you might have to be a little bit cluey about knowing the side effects of the medicines they're taking. Are you concerned about side effects is probably a better one. Is the cost of the medicine too much? Maybe you could phrase that a different way as well. So we know that knowledge, their medicine beliefs, their memory, whether they're self-sufficient or somebody else helps them, their vision or their ability to access medicine all contribute to non-compliance. So step 6, consider the adverse effects of each medicine. Do you know the adverse effects of all the medicines? Probably not, but you need to know where to find it. Is the patient reporting any of the effects that you've now found? This is where your communication needs to be considered. You don't wish to show that the patient should be fearful. We need to talk to them in a way that stops them being distressed. Again, we're left with more questions and more facts for your report. One of the tricks to asking about adverse effects is asking the patient if they have particular symptoms, and if you know what the adverse effects of the drug are, then it's possible when you write your report that you can identify that symptom with that particular drug. If interactions are occurring, how can you know if that's actually impacting on the patient? If you know the adverse effects, then you know what the impact's going to be. I just wanted to talk a little bit about statistics in adverse effects. Rare adverse effects are when 1 in 1,000 patients are affected. So if a GP practice has 500 patients on that drug, the GP only has a 50% chance of seeing that adverse effect. Consider this. If a million patients are taking the medicine, there is a probability of 1,000 patients experiencing adverse effects. So you may not actually have a GP that you're working with that's actually seen a particular adverse effect of a drug. Maybe they simply don't believe you. Maybe you don't believe you. We'll talk about more of that on the day. So let's have a look at pathology. Is there anything abnormal? Normally pharmacists don't receive pathology, but it will be part of the referral in an HMR, and it'll be available for an RMMR. So you need to check and see if anything's abnormal. It's also good to see if pathology supports the conditions. Consider that iron deficient patient. Also, it's important to see if there's pathology to support the medicines. A good example would be cholesterol-lowering medicine. One would expect to see pathology where cholesterol and perhaps triglycerides are elevated and then reduced to normal range as the medicines take effect. The RCPA manual from the Royal College of Pathologists Australasia can be a great resource for you. Pharmacists need to become familiar with what pathology information needs. For example, if hemoglobin is low in a full blood count, what does that mean? Consider sodium and potassium. How does a patient feel when they're below normal range? If you don't know, consider how you'd find out. Step 8. Calculate creatinine clearance and BMI. This can identify any issues with renal function. Because serum creatinine is an important indicator of renal function, it's an easily measured byproduct of muscle metabolism. So creatinine clearance rate is the volume of blood plasma that's cleared of creatinine per unit of time and is a useful measure for approximating glomerular filtration rate. So we will be calculating creatinine clearance when we meet. While we can do the calculation on a calculator, there are numerous online calculators, and there's one from the kidney.org.au, there's one from EMH, and there's one in MIMS. Excuse me. Body mass index, or BMI, is a useful gauge of normal weight and can be a useful tool to use when recommending diet and exercise. Again, there are numerous online calculators. So this is the one from the Kidney Handbook. It's quite important if you use online calculators that you make sure that they're Australian ones, otherwise you might be getting the wrong answer. Be sure to use lean body weight, gender and age when you're calculating. Step 9, consider interactions. Do you have an interactions program? If not, you need to gain access to one. Once patients start taking more than 5 medicines, there is a risk of interactions. How do you identify if an interaction is indeed occurring? By asking the patient, of course. If higher blood levels are the result when a patient is experiencing more than one medicine, then you're going to get adverse effects. It could mean that the blood pressure is too low or the blood glucose is too low. Again, more questions to ask and more facts for your report. So what resources do you have available? These are the common ones, and we probably would expect you to have all of them. So AMH, let's see if we can bring them up. I'm sure you've all seen that. Therapeutic guidelines, EMIMS, NPS, Veterans Mates, and there are others. You will be expected, when you're doing your medication review cases, to use all of these at least. There should be a wide range of resources that you use when you're doing the cases. Step 10 is the final step, and it's the clinical assessment. So what are the medication-related issues? What questions do you need to ask? And how will you try to resolve the issues? Once you've done this, you will have set up some questions to ask the patient, and for that you will need to consider your communication. So, is this communication counselling? Possibly on the best use of the medicines. Is it interviewing? Definitely to find out some answers. Is it teaching? Possibly, because they need to find out information about their condition. I thought we'd just go into a little bit more about medication-related problems in case you hadn't considered the breadth of the issues that we're going to be looking at. It's a very common list. Incorrect medication choice, indication doesn't support it, the dose is too low, no diagnosis for the drug, there's a contraindication for this drug, maybe the patient's elderly and it's not suitable for elderly patients. Maybe they've been on the drug for an unnecessarily long time. Maybe there's two drugs doing the same job. Maybe the dose is too high. Maybe they're not administering the drugs. Maybe there's an interaction. Maybe there's drugs not being effective. Maybe there's side effects. Maybe the patient doesn't know anything about the drugs they're using. Maybe they're not satisfied with the outcome, or maybe they're just fearful of getting side effects. In case you didn't think that was good enough, the Merck manual is very good for providing you medication examples. A little bit more detail perhaps. So they've got quite a lot on medication interactions, and it might be drug-food or drug supplement, drug-disease interaction. There may be inadequate monitoring. Maybe a medical problem is being treated with the correct drug, but the patient is not being monitored for complications or effectiveness. Maybe it's an inappropriate medication selection. The medical problem, maybe it's an old-fashioned drug. Maybe it's inappropriate treatment, patients taking medication for no reason. Maybe it's lack of patient adherence, the correct medication for the problem but the patient's not taking it. Maybe it's overdosage. There's a feeling sometimes that if you take half a tablet, then a whole tablet will be better. Poor communication. Drugs are inappropriately continued or stopped when care is transitioned. So this sometimes happens in aged care, particularly where the patient's been on something in hospital and when they go back to the facility, the drug is stopped. Maybe there's underprescribing. There's a medical problem and there's not enough, maybe there's no medicine for it at all, which would be an untreated medical problem. So the outcome of the investigation is that you will be able to identify those medication-related problems that affect your patient. You will be able to prepare some questions for your patient to help identify missing information. You will be able to prioritise which are the most important issues. You will be able to write a report to your general practitioner about what you found, what the problems were, and some strategies on how to resolve them. Now we've found the medication-related problems, how can we resolve them or prevent them? If adherence is an issue, then using motivational interviewing when we talk to the patient, we can try and resolve. If the doses are too high or too low, that can be a recommendation in your report. If there is an untreated condition, it can be a recommendation in your report. If there are interactions, you can report the patient is having symptoms of excess medicine. That could be in your report. bring your ideas to the workshop. We hope you've enjoyed the second webinar of Stage 1, and we look forward to greeting you again very soon. Please bring any questions with you to the one-day workshop. We use the evaluations to improve our courses, so we hope that you complete the evaluation for this module. And please complete the assessment. Thank you again for listening.